actually is number 1, followed very closely by breast as far as incidence is concerned. And in terms of mortality, again, a very high, disproportionately high mortality for lung cancer at almost 20% compared to breast, which is about 6.5. So this is worldwide data. And the reasons are many. Partly there are no real lung, screening programs for lung cancer. And then in many parts of the world, especially in LMIC settings, lung cancer was usually misdiagnosed as some sort of an infective condition. So by the time many patients who present with lung cancer usually present at an advanced stage. And then we're all aware of the oncogenic drivers of non-small cell lung cancer, EGFR, KRAS, ALK, and then of course there are so many unknowns, but there are all these drivers of lung cancer which are oncogenic and targetable. So you should be aware of that as well. In terms of timelines of non-squamous cell lung cancer treatment, you find that EGFR was first discovered as a mutation in lung adenocarcinoma, and that it was found to be sensitive to EGFR inhibitors way back in 2004. And then as we go along, in 2012, the TCGA genomic characterization of lung adenocarcinoma was completed. During that time, RET and ROS1 fusions were described in lung adenocarcinoma. And the genomic landscape of lung squamous cell carcinoma was concluded in 2014. And crizotinib was effective in ROS1 positive non-squamous cell lung carcinoma in that year as well. And then in 2017, we had FMI, Foundation 1, comprehensive genomic panel was approved for non-small cell lung cancer. And the Ventana ALK assay was also approved as a companion diagnostic for crizotinib in ALK positive non-small cell cancer. And then as we come along in then we had other drugs that were approved for NTRK fusions because there are all these oncogenic drivers. And in 2021, atezolizumab was approved for early non-small cell lung cancer. And then in 2022, we have selpercatinib approved for RET fusion. So there's a lot of, and that is, the evolution of treatment is like describing what's happening as far as the diagnostic field is concerned for lung cancer. So when you look at specifically PD-L1, it can be expressed on tumor cells, but it is also expressed on tumor infiltrating immune cells in the tumor microenvironment. It is an immune checkpoint inhibitor or a protein, and it regulates the immune response to prevent. So you don't want your T cells, your CD8 killer cells to come in and mount such an aggressive response in a site of inflammation or tumor, that what happens then, you get an autoimmunity. It doesn't then it was not able to recognize self from non-self. So the reason PD-L1 exists in nature is that it tempers or it regulates the kind of response, the immune response, a tumor or a cell or an individual generates. So like I said, it is usually expressed and normally expressed on these activated T cells, immune cells, immune cells which are the antigen presenting cells, which are your macrophages and your B cells. And the expression of PD-L1 on these immune cells or your antigen presenting cells are in response to inflammation and high level of gamma interferon. And so what this PD-L1 does, it binds your PD-1 and B7 on your CD8 positive T cells, which are your active T cells. And so cancers have adapted themselves, tumor cells have adapted themselves, they have become like your antigen presenting cells, and they express PD-L1 as a resistance mechanism to attenuate the anti-tumor host response. So then what they do, PD-L1 then binds to PD-1 and it inhibits T cell activation and induces T cell exhaustion. So if you were to block with a drug like atezolizumab, you then block that PD-L1, PD-1 interaction, what then happens, you are reactivating your T cells, and your T cells then become immunologically active and are able to then form like a defense against those tumor cells. So that's the whole idea behind your PD-1, PD-L1 blockade. But when you look at PD-L1 expression on the T cells, remember on the tumor cells versus your immune cells. Remember that we said PD-L1 is on immune cells, which are your antigen presenting cells like your macrophages and your B cells, but they're also present on the tumor cells. The expression on tumor cells versus your immune cells actually varies between the different tumor types. So when you look at the expression subgroups in key clinical trials, you find that in triple-negative breast cancer, as an example, immune cells are the ones that express more PD-L1 than the tumor cells. So if you combine tumor cells, it will only be 2 plus 7 is 9% of your tumor cells will express PD-L1, but your immune cells will be 34 plus 7, so that's a higher proportion of your immune cells will express PD-L1. And that's through the Impassion 130 trial. In non-small cell lung cancer, on the other hand, there is a higher prevalence of PD-L1 on tumor cells compared with the case in triple-negative breast cancer. So the popular trial, you can see in tumor cells only is 11%, in tumor cells plus immune cells is 26%. So it goes up to 37% in tumor cells. And so what has happened, that because of this variety of expression, there are different approaches in clinical trials. So therefore, we have ended up with different clones, different scoring systems, and different cutoffs in different tumor types. So it's a very sort of a complex, and you need to be able to know, I mean, when you're scoring, which tumor type is it, which clone is it, am I supposed to score the tumor cells only, or am I scoring both tumor cells and immune cells? So what are the CAP recommendations on PD-L1 testing specifically for non-small cell lung cancer? The clinical impact of what we call immune checkpoint inhibitors, these are anti-PD-L1, PD-1, are profound for patients with non-small cell lung cancer. And clinical trials have demonstrated that drugs that block PD-1 encoded by PDCD1 and PD-L1, also known as B7H1, and it's encoded by CD274, lead to significant improvements in both response and survival relative to if you were to only provide patients with conventional chemotherapy in patients with advanced non-small cell lung cancer. And like I mentioned, that testing for these PD-1 antibodies is a specifically complex process with the individual therapies, along with what we said, different tumor types, companion diagnostics approved by the FDA, US FDA. So therefore, due to these methodological variabilities of different testing modalities, there can be some uncertainty. Which test do you select? Which clone do you select? What drug will the patient be getting? And so there's all this uncertainty surrounding PD-L1 testing. So what CAP did, they convened a working group of experts in non-small cell lung cancer and those who do biomarker testing to develop what they call evidence-based recommendations in accordance with the standards, so that you have trustworthy clinical guidelines that are established by the National Academy of Medicine. So what CAP has done, it recommends the use of clinically validated, what we call companion diagnostics. So a test that is mapped with the therapy. So that's what they recommend. However, they also recognize that in settings such as ours, where access to these companion diagnostics may be such a challenge because of the pricing, because these are very, very expensive. I think when we costed ours, we were looking at 35,000 shillings just for the antibody without anything else. So you can imagine it's a very, very expensive test, especially for us in our setting. So they also endorse, this expert panel says you could have what we call laboratory developed tests, but as long as you validate these lab developed tests against these standardized companion diagnostics that have been clinically validated. So you need to make sure that if you are bringing it in-house, you do that, like we have done for the longest time. In our lab, we used a lab-developed test for HER2 as an example. We didn't use the 4B, the one from Ventana. We were using the HER2, concentrated HER2 antibody. We would dilute it and use it, but we made sure that we had validated it against, a clinically validated, FDA-approved clone, as well as ensuring that we are in an EQA program. So that's very, very important, that you must do technical validation against one or more of the approved companion diagnostics PD-L1 assays. And so the data currently is showing that whether you use 23C3 or 28.8 or SP263, 22C3 is DACO, SP263 is the Roche or Ventana. They are interchangeable, but the SP142 is not. So you cannot say I'm using SP142 for Pembro. You need to, because there are issues with the staining for the SP142. So when you look at the PD-L1 companion diagnostic assays, we have the 22C3 from DACO. The platform is DACO. We have the 28.8 from, again, DACO. We have the SP142 and the SP263, both of which we are going to touch on today, and Amelia is going to go through the scoring for these ones. And those are from Ventana. And then you look at the cut point, the expression. So tumor proportion score for the 22C3 is more than 1%, is considered positive. And tumor proportion score of more than equal to 50% is a high PD-L1. And you can see the drugs. So if you have more than 1%, you can use Pembro as a monotherapy. And if you have more than 50%, semiplimab can be used. And then if you look at the Ventana ones, the TPS, the 142, you either look at the tumor proportion score or the immune cell score, and you can use Atezo. And the SP263, more than or equal to 1% tumor cell proportion, you can use the Atezo. So there are different drugs, even for the same tumor. Different drugs, different cutoff points. So PD-L1 tumor proportion score is a useful biomarker because it informs treatment decision making. And has also been found that the higher your PDL1 score, the higher the response to anti-PDL1 and the higher survival following immunotherapy with PDL1 and PDL1 inhibitors alone or in combination with chemotherapy or and/or CTLA-4 inhibitors. So these are the guidelines about when you can use monotherapy depending upon these trials, like the Keynote 024, the Impassion 110, what you can use, what are the tumor proportion scores, but the main thing here is that the patient must to have what they call an ECOG performance in a relatively good health, almost normal, 0 to 1 is your ECOG performance for you to be eligible, to be able to demonstrate that advantage. So we also know that it's not just the PDL1 we are testing in non-small cell lung cancer. We have all these fusions, ALK, BRAF, EGFR, T790, which is an acquired resistance to EGFR inhibitors, and PDL1, PD1 at the, which is immunohistochemistry. So there are all these FDA-approved drugs. But if you look at the updated molecular testing guidelines for lung cancer patients for treatment with TKIs, in any patient who has an advanced non-small cell lung cancer, the must do biomarkers currently are EGFR, ALK, and ROS1. And then the others come, slightly less more. So that's like a must do. You must do those three. So genomic biomarker testing in conjunction with PDL1 IHC has been indicated to optimize therapy selection. So if you have an oncogenic driver, EGFR or ALK, then you should not give, or the patient should not be, even if the PDL1 is tested, the patient should not be given immune therapy. And the reason is that concurrent, if you give concurrent EGFR TKIs plus your PD1 inhibitor, it's actually associated with severe adverse immune-related events. So patients with targetable oncogene like EGFR, ALK, ROS derive substantial benefit from appropriate targeted therapy in the first-line setting. So you give them that, and you can see that in the dash, in the whatever, that if you have EGFR positive patients, then you benefit from your chemo plus and or minus TKIs, sorry. So what are the considerations then for PDL1 testing? What specimens and what testing provide accurate results for both PDL1 and TMB? I'm not going to touch on tumor mutational burden because they may look synonymous, but they are not. So I'm just going to focus on PDL1. The sample selection. Should we go for a biopsy or should you go for resection? Should you go for a primary tumor or should you go for the MET sample? Should you go for histology or should you go for cell blocks? Then you realize because of the clones, there are different clones and the staining variability between these different clones. And how then do you score these PDL1 levels? So if you look at, this is an example of a lung cancer, non-small cell lung adeno. And in the same tumor, this is a resection specimen, you can have a well-differentiated, relatively well-differentiated area. And in that same, tumor, you can have areas like this at the bottom panel, which are very poorly differentiated. Now, if you had a biopsy sample, you could sample either one of these and you'd still you make a mistake in terms of the PDL1 expression. So of course, you'd rather have the resection specimen, because with a resection, you'd be able to see those areas of heterogeneity and different tumoral patterns. And then not only is there, and again, as you can see here, if you look at the well-differentiated area, the tumor proportion score is less than 1%. These are the number of positive cases, positive tumor cells staining with PD-L1 over the total number of the tumor cells. So you can see here that if you had only the well-differentiated area, it may be the PD-L1 may be reported as negative, yet in that same tumor, you have this poorly differentiated, and you can see the PD-L1 score, the proportion of the tumor cells are really high, like 90 to 100% staining. Other than that, other than there being two histological subtypes in the same tumor, you could also have geographic heterogeneity of PD-L1. And I know Emilia, when she will go through the scoring, she'll explain how you deal with that, because it can be a bit of a challenge. So you could, just like in HER2, you could have areas that are 90, 100%, and you could have areas that are like really, really low. So how do you then calculate the PD-L1 score when you have geographic heterogeneity of PD-L1 expression? So when you're thinking of specimens, it's been found and it's been reported that concordance between a small biopsy and a resected specimen for PD-L1 range from 83% to 95% at the 50% cutoff, right? So it's pretty decent at the 50% cutoff. But when you go to small biopsies, for the 1% cutoff, it's 77 to 8, at the 1% cutoff, the concordance between biopsies and resection is much lower, the highest coming concordance at 86%. So definitely, if you only had a biopsy specimen, you'd get a lower score than if you had a resection specimen. However, CAP guidelines state that despite this intratumoral heterogeneity of PD-L1 expression, testing of small biopsies is acceptable. So it's not like you say, well, I have to wait for a resection. You can go ahead and test on the small biopsies. What about primary versus MET? Which sample should you use? Should you use the primary tumor or the metastatic? Again, tumor proportion score obtained from the primary tumor and metastatic lesions are discordant in resected specimens. So if you had a primary tumor and you had a resection specimen and you looked at a MET and you compared that with the resection specimen, 20 to 30% of cases, so at 1% and 50%, at 1% and 50% cutoffs. So there are currently no studies evaluating the response rate to PD-1 or PD-L1 immunotherapy based upon testing from different sites. So there are no. So do you take from the lung? Do you take from which site? Do you take it from? There are no studies to demonstrate the response rate comparison. So if you have samples from synchronous specimens and you have them from multiple sites, what you need to select for your PD-L1 testing is the specimen of the best, what we call technical quality. So it should be well-preserved tumor, no necrosis. So those are, a lot of tumors. So those are the ones you would select for your testing. What about score, expression score reporting? So the levels of PD-L1 total proportion, tumor proportion score, again, are also significantly correlated with patient response and with survival following immunotherapy, either in isolation or as a chemoimmunotherapy combination. So you can see how those lines of survival in the PD-L1 more greater than 50%, you can see the survival rate is much, much higher when the PD-L1 is greater or equal to 50% as compared to when it is less, like 1 to 49, and you can see the black and the orange. So then, what about, we have talked about all these 28.8, 22C3, SP263, all these various clones, and SP142. So it's been shown that there is a high concordance of PDL1 expression for 22C3, which is a DACO antibody, 28.8, which is also a DACO antibody, and SP263 companion diagnostic assays. So in a way, you can use them interchangeably while SP142 shows weaker expression. So you can see the tumor there. You see the 28, the proportion score looks similar to the 22C3 and also looks sort of similar to the SP263. So all these three you are going to, whether you call them 30, 40 or 80, 90, you'll call them positive. However, the SP142, which is the Ventana clone, is not considered appropriate for the selection of patients for treatment with pembro, semiplimab or nivolumab. So it's not. So you can only use atezo. So if you test your sample with SP142, it's only been validated clinically for atezolizumab, not the pembro. You can't use it because you can see that it will give you, maybe a false negative. So in terms of when you're scoring, it may be a challenge for us as pathologists to say, well, it is 40%, it's 50%. So there are currently, there's a thought process going around that perhaps rather than saying it's 20% and 10%, can we have sort of ranges, 1 to 10%, 11? It's much easier to provide ranges rather than exact, unless you have an AI, tool. It may be a challenge for many because we are all subjective. We don't see exact numbers. So you could do a semi-quantitative, and it's not wrong if you were to employ that. So the PDL1 assessment will decide the preferred drug and the combination. So in the MET lung cancer, if you have a tumor proportion score or of greater or equal to 50%, you can use pembro as a monotherapy. And if it is TPS greater or equal to 1%, these are all the possible combinations that you can use as either monotherapy or as a combined immunotherapy chemotherapy. In the lower stage lung cancer, you can use in the neoadjuvant setting pembro plus chemotherapy, or in the adjuvant setting 1B, 3A, you could use pembro or atezolizumab when you have a TPS or a tumor proportion score of more equal to 1%. So take home points: PDL1 IHC testing is a cornerstone of non-small cell lung cancer biomarker testing. Other factors may contribute to management decisions regarding whether you're giving immunotherapy in patients with non-small cell, including the presence of genomic driver alterations such as EGFR and ALK. Remember we said if you have those driver mutations, PDL1, anti-PDL1, PD1 is actually contraindicated as therapy for those patients. And there are biological and there are technical variables that influence the PDL1 expression status. And so when you're implementing the assay, you need to be aware of this, variabilities both in biology and technical assays implementation and how you report them. Regulatory approved. Of course, the approval is always clinically validated. PDL1 diagnostics are recommended. However, if you want to begin the service and you have the option of an LDT, lab developed test, it's fine, except you must make sure that there is validation against the approved companion diagnostics. So these guidelines are available. In fact, they were just published in Archives of Pathology and Laboratory Medicine in April of this year. These are the CAP guidelines. And if you go to Pathology Outlines, you'll find really nicely indicated. They give all the explanatory notes and how you're supposed to score for different tumors and what are the indications for PDL1 testing in various tumors for various clones. and the cutoff points as well. So you don't have to, cram them. They are available once you decide to start testing. So thank you very much. I'll let Anne continue, and then we can take some questions. Thank you. Anne?
Yes, thank you, Shine. Very nice presentation. Let me share my screen. And my presentation is going to be short, so it's good we will have time for questions. Can you hear me?
Can you repeat? Can you repeat?
I said, can you hear me?
Yes.
Okay. So I said, ready to share my presentation.
Okay. Yeah, you can share your presentation. Any questions meanwhile when she shares? So Emilia will go through the 263 and the 142 and show you a case examples of what to score and how to score.
Can you see my screen? Can you hear me?
Well, remote and hear well.
In the room, can you hear me and see my screen?
Yes.
Okay. So thank you, Shine, for the presentation. And my presentation will be quite short because the quality and best practices for lung cancer are basically the same as for breast cancer. So for the pre-analytic, you can refer to the paper I was presenting before, and here is just an extraction from the interpretation guide that goes with the SP263 non-small cell lung cancer. And you can see that the sample has to be fixed in 10% NBF, and you have to cut 4 micron sections. So really, what I said is that nothing changed. The time to stabilization is important. The method of stabilization is important. Method of processing. All the parameters are exactly the same. Then in terms of assay, you explain very well, Shane, that each assay has been optimized as a complete system. So the instrument, the reagent, the interpretation guide, the software, the detection, the antibody. So these are always the validated assay that are the reference. And if people want to use lab developed tests, they have to validate against this assay. And as you said, participate to external quality assessments that are important to check the quality. And the pillars have not changed: on-site control, monitor the rates, and participate to AQA. So on-site control in terms of PDL1 testing, what is recommended for PDL1 SP142 is tonsil, and what is recommended for PDL1 SP263 as per package insert is placenta, but also what is recommended is a piece of tonsil as recommended, for example, by Nordic QC. And if we look at the positivity rate, what we have is first as a check is your percentage of non-small cell lung carcinoma. And the rate we could find is in the literature are from 80 to 85%. And then the PDL1 positivity rate, uh, as you can see, is very wide because it's based on a review that you can see the reference below, and they looked at a lot of yeah, research, clinical trial, and they look at all cutoffs. So it may vary from 24 to 60%, which is quite wide. But if you start to monitor with a certain assay on what you are doing in your lab, then you will see from year to year that you shouldn't have that much variation. So monitoring rate is a way to check that your process is going well. And same as for breast, participation to external quality assessments is part of the quality. I would like to add that for external quality assessments, Um, in the world external quality assessment, there is external, which means checking the quality externally. If you cannot participate to external quality assessment like ASCOCAP, like Nordic QC, like UK NEQUAS, what you can do as a minimum of quality check is to call a friend lab and regularly to exchange, let's say you send 5 or 10 positive cases and negative cases, and you ask them to run the same cases and then you compare the result. So it's not as, let's say, as efficient as participating to organization like Nordic QC, but it's already quite good because if you don't get the same result, then you can sit and discuss together and understand what's going on. So I told you it was quite short because the pre-analytic and quality are the same no matter which organ marker are tested. So now we can maybe have a few time for questions.
Raise a question.
So I just want a clarification. So in case of PDL1, control, positive control will depend on which clone you have. It, that's what I've gathered. Despite the different way of interpreting them, so in terms of control, if I'm testing triple negative breasts, it really depends on the which clone of and the antibody I have, so that I can use as a positive control. I just want to understand.
Yeah, so you can use placenta for the 263, but you can also use the tonsil, the same for the other one. Anne?
Yeah, so I think for it's good to put a piece of tonsil for all of them. Then you have the same control block. And as a recommendation for the package insert, Roche recommend placenta, but you will have less differential expression in the placenta. And if people wonder why is there placenta in the package insert, if you remember the presentation from Emilia, when a test is put on market, the manufacturer is putting the test on market together with instruction, and then the I would say the pathologists and the oncologists, then the science evolved, and that's why in the package insert of SP263 it's recommended placenta, but it's good practice to put tonsil, and with tonsil you can cover all clones. I must admit I don't know what is recommended for the other clones. So with tonsil you cover all everything.
Okay.
Maybe I can comment on that as well.
Yes.
I also don't know what the 22C3 and 28.8 recommend in their package insert, but I think looking at Nordic QC, patient who has vast experience and looked at all these antibodies, their conclusion is that tonsil covers also aspects, and you have the range from weak to strong in the tonsil.
Thank you. Amelia, do you want to continue with your presentation instead of a break now?
Yes.
Yes, thank you.
If it's fine with you, I'll
Yes, I think it's okay with everyone. Thank you.
So then I'll just start the slideshow as well. So the purpose now is to go through first SP263 and then SP142, so that you'll understand a little bit of the differences between these assays. And as Professor Jean said, SP263 is the one that is most equivalent with the other CDX clones out on the market, like the 22C3 and 28.8. And it also has the widest clinical use because it has more of the different drug approvals. So let's start with that one. Just remember that the assay, what we consider an assay today is really not only the antibody. So it's the antibody together with the platform where it has been validated, together with the detection kit for which it was also optimized. And in the case of Ventana SP263, it's the OptiView detection kit that is being used. Of course, from a manufacturer, we always include the negative reagent control as well. And then, of course, you need to have a scoring system. And now you just learned about how CAP approach to try to bring some clarity and try to make it a little bit easier amongst all these different scoring systems. And I think that's really good, because we have to try to remember the tumor proportional scores and the combined positive score. With a CAP, they go for the tumor proportional score as being the one factor that seems to work well for most antibodies. And this is also what we use for the SP263. So the range of expression can be very different with the SP263. And it is, you also saw that in the slides, it's really depending on the morphology of the tumor and if it's well differentiated, low differentiated, etc. But also of the biology. So how much of an interaction between immune cells and tumor cells do you really have? And so what is it that triggers this upregulation of PD-L1 on the tumor cells? So here you can see these examples of really strong membranous staining to a rather weak membranous staining. We always look at the membranous staining and not the cytoplasmic, again, because these are drugs that want to interact with the surface of the tumor cells, as well as the immune cells, because the drugs also interact with immune cells, especially atezolizumab. So as I said, we look at the membranous staining. It can be partial and it can be complete. Both are fine. It doesn't need to be complete. We count everything. And we count each cell with either a partial or complete membranous staining. We very often see basolateral staining as well. That is counted, so perfectly acceptable. The only thing that's not acceptable is if you only have basal staining. So it needs to be lateral as well. It's common to see this heterogeneously staining of different intensity across the slide, and especially if you look at resection samples, that will be more obvious. But in the case of PD-L1, we take all intensity levels into account. There is a lot of immune cells usually present. They do pick up the staining, and that we don't include it in the scoring, but it can give some challenges in trying to estimate the number of tumor cells and then subtract mentally the immune cell staining from that percentage of tumor cells. And that is also one of the reasons why the negative range control, or maybe not the immune cells, but in non-small cell lung cancer, there are a lot of other artifacts as well. There might be pigments from macrophages digesting, or there might be anthracosis and other issues in the sample that gives a color on the slide. So in non-small cell lung cancer, I do believe that the negative reagent control can be particularly useful. So we can go to some examples, and this is to illustrate this basolateral staining, as I mentioned. So all this type of basolateral staining is included and accepted in the scoring, and I think we can see some complete membranous staining. So what we can see here, these are macrophages, and remember that it's only tumor cells that are counted. Here's another example where we have a mix of basolateral and only basal membrane staining. So the isolated membrane staining is not included in the scoring because we can't really be sure that that's expressed by the tumor cells. So we want to have it along the lateral sides of the tumor cells. Of course, that is extremely hard to subtract and add when you do the assessment of how many percents of the tumor cells, especially if you have a big sample. But you just need to try to give yourself a perception of how much in a field that is consisting of just basal or how much of basolateral. So maybe in a slide like this, you can see that this whole area you would just remove from scoring, and then maybe include more of this and over here, and of course do not include macrophages or necrotic cells. There might be occasions where we see this perinuclear cytoplasmic staining that it just look like these small granules or dots almost in the cytoplasm. That is not included. It needs to be membranous staining. So we need to see lines to score because this is not druggable from a therapeutic perspective. So just saying again then that the immune cells, and we have so many different immune cells in the lung tissue. So we have lymphocytes, macrophages, histocytes, reticular dendritic cells, and they can all display a range of PD-L1 expression. And now I see hear an echo. Is it a mic that is on? Oh, now it's better. Okay, of course there can also be plasma cells and neutrophils, just to be aware, but they are not as common. And the staining pattern of immune cells is equally heterogeneous as the heterogeneous staining of the tumor cells. So just maybe also to emphasize that even if they're very common to have immune cells in lung tissue, it cannot be reliable as an internal control. You really need to have the on-slide control as well. And as we discussed before, the tonsil has proven to be a very, very good sample to show the range of intensity and in different compartments of the tissue. This is an example of alveolar macrophages. And in this case, you can see that the tumor cells over here, they are negative in the PD-L1 staining, and the macrophages, they pick up a lot of moderate to strong staining. Should not be counted. So again, just as for the HER2 dual-ish, the more challenging an assay or a test is, the more important the H&E becomes. It's mandatory to have the H&E and really refer back to which area. Make sure you are identifying the right cell types in your assessment. And here is an example of another type of immune cell staining. So you can see in this one we have a much more punctuate, usually seen in lymphocytes, and then we have some more of these that are similar to tumor cells, but this is also an immune cell. So you can have both this membranous staining and this granular pattern in immune cells. So you compare this to the previous one that in macrophages that really look like tumor cells. This one is easier to just recognize immediately as being immune cells stained. And again, you can see that the tumor cells that we see over here, they are negative in the PD-L1. Here's an example of what I said is rather rare to have plasma cells, but here's what a case of plasma cells might look like in PD-L1. And another example of what is also quite rare to have neutrophils. Here's an example of what they might look like. Should also not be scored. Anne mentioned to you the pre-analytics conditions. For the SP263, I just wanted to highlight that, of course, you should stain the slide as soon as possible after preparation, but it has actually been validated that it is a quite stable epitope. So it has shown adequate staining within 12 months after cutting, if you store them, well, both actually, if you store them cold and at higher levels, higher degrees. So in that sense, it is a robust antigen and a robust assay. We can compare that. I have a similar slide on SP142 that is not as stable. When it comes to the scoring, it's very simple, and Professor Shane already showed you how you can use the different intervals to try to be a little bit more concordant, because actual percentages is of course hard unless you have a digital algorithm. But these are the basics for the scoring. The partial and/or complete membranous staining, basolateral staining, if you have both basal and lateral, and then the scoring percentages is ranging from 0 to 100. The important cutoffs when it comes to this is really to remember, depending on the different drug approvals, that the cutoffs that we care most about is the 1% that we see for several drugs as one important cutoff, and it's the 50%. And then we have for nivolumab, we also have 5 and 10%. All these different cutoffs are related to different lines of treatment. So for instance, for pembrolizumab, if you want to treat first-line treatment, then you require 50%. If it's a second-line treatment, you can actually go down to 1%. So it's almost impossible to remember this by heart. Personally, I find it impossible. I always need to refer back to guidelines, and Pathology Outlines is an excellent source of that as well. But national guidelines are even more important, because sometimes, for instance, for Pembro, they have approved the 1% cutoff already earlier in the first line, whereas outside of US, most countries have gone with the 50% in the first line. And that is really depending on how the interpretation from the regulatory bodies on the benefit that was shown in the clinical studies. There are some benefits for all patients, but it's not just maybe justifiable if you don't have extremely a lot of money in your healthcare system. And that's why regulatory bodies say sometimes opt for different thresholds, really just to try to select the population with the most benefit and where it makes most sense, and also to try to relate it to other types of therapies that are available. So report the percentage of cells. Feel free to use intervals, but be very aware of these important cutoffs of 1%, 50%, and in some cases 5 and 10. So the communication with the oncologist and what they have in their toolbox with regards to available therapies is really important to have together a good discussion, so that the patients can be treated as good as possible. So that said about the scoring, now let's go through some examples, and I just have a couple of different examples of typical patterns. So this is a non-small cell lung cancer where we can't really see any tumor cells, pretty much as you saw in the previous example as well. Here we can see a few immune cells, and we see something that is more regarded an artifact in here, but it's 0% tumor cells. Here's another example of a low differentiated tumor with a little bit more challenging staining pattern, because here you can see some tumor cells, but in the other, what is depicted here, you have some examples of different immune cell staining. So of course that is challenging in a case like this, to try to identify what is a tumor cell and what is not, so that you can derive an accurate score. Usually the best way to approach these cases, in my view, is to always alternate between high and low magnification. In the high magnification, convince yourself if or if not this is a tumor cell, and then in low magnification, try to estimate how much of that you have in the overall tumor sample. So here is an example. Again, actually we have a few more here that are clearly positive with PD-L1. And I just put a grid on here, and that can also be done in the microscope. You can use that as a way to just guide you into how much is 10% of something. So here, if we put 10 different tiles, you see that one tile here would be 10% of the area. Then, of course, we need to remove all the stroma, but at least it gives you some help to understand, okay, if I have these two here, and these tumor areas that are rather equally distributed in each of these tiles, yeah, then we can say that it is approximately 1% of the tumor cells that stay positively, but it's definitely not 10%, and it's not 5% either. But that's a little help to use a grid in your microscope or on your microscope. Another example, I put the grid here as well, and here you can see some very weakly positively stained tumor cells, and here a little bit more weak to moderate tumor cells. This is more than 1%, and if we add these areas up, we could be not above 5%, but it's reasonable to believe it's 3% and definitely more than 1%. And of course, if you put this grid in different areas, you just repeat that all over the sample, and then you will need to mentally add or subtract until you reach a final score. Yet another example, again, we have more of these areas, and not all of them have been encircled with blue. We have some here as well with positive tumor cells, and if we add them all up, we will be much closer to 10% than in the previous examples. If we look at the whole resection and a much bigger surface, because now we went through high power, it might look like this. So here again, the heterogeneity is very obvious. We have the whole tumor area here. We have a clearly positive area over here. The rest of it seems to be very low. Maybe some here you need to go to high magnification to confirm if this is in tumor cells or if it's just immune cells and macrophages lying down here. But here it is confirmed that we have tumor cells. So how do we then try to estimate the percentage? So if this area is of this size, we try to divide the rest of the tumor in equally sized areas, and then we can just say, okay, so we approximately fit 6 areas like that, and then we can make a calculation and derive it something close to 15%. So that's a helpful approach. This is another approach where we have more heterogeneity, so it's not only one area, but it's several areas where we have positive tumor cells. Then it can be helpful to just divide the whole area, the whole tumor in equally sized or somewhat equally sized areas, and then see, okay, for this area, how much do I have? Well, I have 35% if I include this as well, because this is how much tumor I have here. And here we get up to 50% of the tumors that have a membranous staining. And over here is just very little that doesn't have, so up to 90%, and here's 25. And then you have these different ranges, and you can average it out. So in this case, the average would be 50%. When we are in these cases, so this is a case where we have much more staining, but we have the heterogeneity. So maybe the only challenge here is really to make sure that you also include the weakly stained areas. So even if it doesn't look as positive as over here, we do have positive cells here as well as here. So altogether, we're well above 50%, and 80% is an easy area to be in, because we so far from the 50%, so it doesn't take much time. Just make sure that you don't underscore it just because you're happy to see the moderate to strong. Do include the weak as well. And here's one very nice case that you don't really need to spend time on at all, because everything is stained for PD-1. But you can also see the immune cells in here. And again, going back to the weak staining, this case also has a relatively high percentage, but it's just so weak person and always try to convince yourself of something else. And especially useful in a case like this where you have to take the weak into consideration. I have a few more examples for SP263, and I've took the fine needle aspiration and the cell block samples that you can utilize. Because the good thing about the tumor cell scoring algorithms, which applies to especially SP263, and I don't know if the drug clones have been validated for fine needle aspiration, but the good thing is that if we only have tumor cells, then fine needle aspiration is more reliable. And the assay has been validated for fine needle samples. Of course, it's really, really good to make cell blocks and to treat it pre-analytically the same way as you treat histological samples. And you might have some immune cells as well in those samples, but usually you get less compared to histology samples. Equally important as for when you're dealing with a biopsy or resection is, of course, that you need the H&E, because you always need to confirm what type of cell are you dealing with. So here is one example. For instance, we have these tumor fragments over here that we can also see on the IHC, but what is picking up the immune reaction is really only seen in scattered immune cells and not in the tumor cells. So H&E is really important. Another nice tumor fragment, and here you can see the PD-1 membrane stain. It's very, very light, but still. We also have cytoplasmic staining very often in PD-1. I personally believe that it's the SP263 is quite crisp, so it's usually not too much of a challenge, but just be aware that you don't overinterpret because of the cytoplasmic staining, and it might require a little bit of a higher magnification to look at it. And yet another example of different intensity ranges of PD-1 staining. As well as in histology samples, you might have macrophages, as I mentioned, and here you see one of these examples of just digested pigmentation in macrophages that you shouldn't confuse with PD-1. But it's clearly quite straightforward to identify the tumor cells and just confirm that these are negative in this case. What we haven't showed you before, but I have this slide, is we don't, it's not only important with external quality assessment when it comes to the technical parts of an assay, the interpretation is also important, that we always, harmonize ourselves and compare with each other, and that we do continuous proficiency tests to make sure that we are within range with our assessments. And we have this collaboration with a lab in the UK that is called CADQUAS, and they provide proficiency tests every month that are free. You just register using this link, and we can send it to you also later. And there you will have the opportunity to score cases and then join a live feedback session where the cases are discussed. So that was for SP263, and then we can talk about the SP142, which is different. Let's see. Let's focus on the differences and how to score it. So SP142 was, and as Professor Shahin said, it's the one that is not concordant and it's not interchangeable with the other assays. So what's its
Any questions from the team here? Do you have some online? Any questions?
Or are you just overwhelmed by PDL1?
You want to continue?
So, thank you, Emilia. I think we break for a tea for 15 minutes.
Does everyone want to break for tea, or you want to continue with Anne, right?
Yes.
Anne's last session. What? Chai? You finish? Okay, so Anne, are you okay to?
It's Emilia. Yeah, it's Emilia that will present now.
Oh, we had done the
I
140.
thought, yeah, and I think you were going to show how to log into the
Oh,
podium.
sorry,
This is
sorry,
actually
sorry.
the fun part, right? Now you will
Yeah,
score
yeah,
yourself,
okay,
and
okay,
it's
yeah.
much easier than just listening to me.
Yes.
Yeah, sorry. So let me just share my screen. Wait a minute. Wait. I have too many windows open. First of all, have you all entered the platform? Because this morning I checked and not everybody had entered the platform. So, and once you enter the platform, so when you enter for the first time, you have to create a login and password, and then you come back. And the only thing you have to enter your name, and then you will receive a mail, and then you continue. And then you have to select the training. So you have two training to select. The first one is SP263. So when you are on home page, you have a list of training, you go in virtual training and you select SP263. And the second one is below the green box. It's also in virtual training and it's SP142. And once you are there, so now let me change my screen so that I can show you how it looks like. So I cannot go through the exactly through what you will see when you first connect, because for sure I have been connected already a lot of time on the platform. So the platform knows me. So when you arrive here, make sure you are on the home page. And then here you have the long list of training. So you go in virtual training. And then you select either to start with SP263 or SP142 in lung. So let's say we go to SP263. If you want, you have some lecture you can go and look at and download as PDF, but it's not mandatory. And then you have different different cases you have to go through. I wanted to change screen, but it's not working. Let me stop sharing and put it there. not sure. Do you see the modules? Module 2, 3, 4?
Yes.
Yeah. So you can go to case review and self-study if you want to see cases. Otherwise, what you have to do is to go in final self-assessment. And here you will have 16 cases to review. So if I go back, review quiz. The thing is, like, I have a little different setup as you. It's always a bit of a nightmare for me to show. There is a bit of a delay. And here there will be some cases appearing. Like no, this is not what I wanted you to see. Let me go to self-study. So this is how you will see the cases. There will be an H&E slide that will appear soon. So you can zoom in, zoom out by scrolling down with the mouse, or you can click on plus, minus. So every time you have an H&E, and then you have the negative control reagent, and then you have the PDL1 case. And this is how you need to score. And once you have decided about your scoring, here below you have the answer. So this one, I'm going to reply something stupid because I'm not a pathologist. So let's say I want to say that it's more than 50, and I know it is not more than 50. You select your answer. If you think you made a mistake, you clear your choice and you give another answer. You clear as this you can do as many times as you want. And then once you are sure about the scoring, you click on check. And now, because I'm in the self-study, I have immediately the answer. So the right answer was more than 1% below 50%. This is the self-study cases. But what you have to do between today and tomorrow is the final self-assessment. And the final self-assessment, you will have to go through all the cases, and at the end, click on final check. And only once you have submitted, you will see what was the right answer. So you can use the self-study to train. For example, now I could say next page. And I can do the next case, the same, the H&E is on top. Then I have the negative reagent control, and then I scroll down and I have the PDL1 IHC staining. So self-study, it's some cases to train, and final self-assessment is what you have to do. Once you have finished with SP263, you go again to the home button. Again, you go in virtual training, and this time you pick up PDL1 SP142 in non-small cell lung cancer. Same principle, you have some lecture as PDF that you can look at and review, and you have also some guided review of cases, a mini self-study, a mini self-assessment, and the one that you need to do for tomorrow is the final self-assessment. Now, Emilia and Shaheen, what did we say? I can't remember. We said, because there is a lot of cases, I think we said for SP263, you do the first. You can do all of them for sure if you want. For SP142, I think
So we don't
Now we will stay online a bit for those that couldn't log into the platform, and we can give. Can you check if everybody was able to log on to the platform?
Yes, I think they have all been able to log in.
Okay.
Yeah, we should not have any issues, but
Perfect.
they can write to you directly if they have any issues yeah, but I doubt. I think everyone's managed. I think the instructions were very, very clear.
Okay, great.
Great. So, and we see you tomorrow. Emilia, thank you so much for your time today. Really appreciate this.
Thank you, my pleasure, and I wish
Thank
you all the best for tomorrow.
Thank you so much. So I think we can go down for tea now, and then we disperse. I mean, we can take off. But tomorrow we convene at 9 again, 9, and we'll try and we'll just go through the cases. So because for her to once you submit the ones you have done, she will be able to see where